Hello and welcome to the topic Approach to a Patient with Hypovolemic Shock. By the end of this session, you should be able to recognize hypovolemic shock, classify hypovolemic shock based on the grading of severity, formulate a management plan for hypovolemic shock, and lastly, carry out the tasks required in the management of hypovolemic shock. Let's get started. The principal function of the circulatory system is to supply oxygen and vital metabolic components to the cells throughout the body, as well as to remove metabolic waste products. Hypovolemic shock is an emergency condition in which severe blood and fluid loss causes the heart to pump less blood to the organs due to decreased preload. If the decrease in arterial blood pressure is severe and protracted, such hypertension will eventually lead to severe hypoperfusion and organ dysfunction. So, we'll be looking at the specific signs and symptoms in hypovolemic shock in the next coming slides. Hypovolemic shock can be a result of fluid loss or blood loss. So, examples of conditions that can cause fluid loss include heat stroke, severe infection, severe burns, and third space loss of fluid. However, hemorrhagic shock is also a hypovolemic shock from blood loss. Traumatic injury is by far the most common cause of hemorrhagic shock, and causes include gastrointestinal bleed, a bleed from ectopic pregnancy, bleeding from surgical interventions, and vaginal bleed. Let's go to the pathophysiology. So, hypovolemic shock symptoms begin to occur when there is decrease in intravascular volume, which subsequently reduce the cardiac output. The decrease in cardiac output results in reduced delivery of oxygen to the tissues in the body and activation of an acute inflammatory response. Decreased delivery of oxygen and other vital nutrients result in reduced production of energy substrate. ATP, thus lactic acid buildup, is observed due to the byproduct of anaerobic metabolism in the tissues. Now, this table outlines the classification of hemorrhagic shock based on its severity grading. The grading depends on parameters as shown in the table. So, if the blood loss is less than 15%, they belong to class 1. Not so tachycardic yet, still normotensive, probably slightly anxious. The fluid requirements here would be crystalloids. For those who encounter blood loss more than 40%, they'll usually be very tachycardic. Their blood pressure might also decrease. They will appear confused or lethargic. They are said to be in class 4 hemorrhagic shock, and here you might even need to consider blood products. Recognizing shock can be a challenge as the signs are pretty subtle before it tips off into a state of decompensation. So, the first signs you want to look for is the peripheral perfusion, and this can be done by the simple CCTVR assessment technique. C for skin color, C for capillary refill, T for temperature, V for pulse volume, and R for rate. So, for the skin color, you want to see a pinkish or reddish appearance. There should be capillary refill time less than 2 seconds. It should be warm in temperature. The pulse volume should be good and the rate should not be tachycardic. Simultaneously assess the general condition of the patient, especially in terms of mental status. Altered mental status is one of the serious complications of shock as it tells us that the brain is not well perfused. Another very important sign to look out for, which will indicate hypovolemia, is low jugular venous pressure. Low jugular venous pressure is indicative of hypovolemia or a distributive form of shock. Not forgetting urine output monitoring. We understand that at a state of circulatory collapse, some organs pay the price earlier than the rest. This is because the body conserves blood flow towards vital organs like the heart, lungs, and the brain. So, the kidneys are one of those first organs to show signs of inadequate tissue perfusion after the skin, and this is manifested as reduced urine output to retain more intravascular blood volume, and as the renal blood flow reduces, this leads to reduced glomerular filtration rate or GFR. Patients' peripheries may also turn cold and clammy and sometimes cyanotic due to the peripheral vasoconstriction that is happening to the efforts to increase blood pressure. So, what happens then? When there is reduced tissue perfusion in the body, obviously this affects the functions of the organs too. So, in the kidneys, you will observe reduced urine formation as the body tries to conserve water. This injures the kidneys and it's called pre-renal cause of acute kidney injury. If not attended to immediately, this damage can further bring about complete renal shutdown to a point of no reversibility. As for the heart, it responds following an adrenergic response secondary to reduced intravascular volume. So, examples of sign you would observe would include tachycardia, hypotension, cold peripheries, and pallor if it's due to blood loss. How about the pulmonary system? Tachypnea or increased rate of respiration is seen due to the stimulation of the central nervous system chemoreceptor by the decrease in pH and hypoxia. Apart from that, respiratory centers too get triggered and provide a feedback mechanisms by stimulating increased work of breathing. How does the reduced circulatory volume in hypovolemic shock affect the brain then? It's simple. When there is less blood flow to your organs, your brain tissue and cells are equally affected, which then leads to the symptoms of cerebral hypoperfusion, which are dizziness, restlessness, anxiety, confusion, drowsiness, or even coma. Finally, let's look at how hypovolemia affects the gastrointestinal system. Decreased intestinal motility due to intestinal hypoperfusion can lead to bilious aspirate, which you will notice as green liquid in the nasogastric tubing. Well, we have looked at the definition, pathophysiology, causes, and complications of hypovolemic shock. Now, let's dive to the principles of management and how you, as a house officer, can participate in the management of such cases. The goals in treating hypovolemic shock are to restore effective circulating blood volume, as well as managing its underlying cause, and importantly, to prevent progression of organ damage or impairment as a consequence of shock. So, the general approach: secure and adequate airway and ventilation, because this is important in hypovolemic shock patients, consistent with the airway, breathing, and circulation of life support. Any compromise in ventilation will only worsen the tissue hypoxia occurring secondary to inadequate perfusion. Thus, tracheal intubation and mechanical ventilation may be needed in cases of decompensation, whereby there's altered mental status and the patient is unable to maintain a patent airway, there is severe respiratory distress, severe metabolic or respiratory acidosis, and hypoxia. Intravenous access is essential for administering intravenous fluids and medications. IV access can be accomplished through the placement of peripheral IV lines or catheterization with central venous lines if rapid and large volumes of fluids are indicated. A bladder catheter should be inserted for ongoing close monitoring of urine output, which indicates response to fluid challenge and therapy. After you insert a branula, you should know which fluids should be given to the patient. Let's look at them individually. So, the three major fluid therapies in restoring circulating volumes are the crystalloids, which is electrolyte based solutions, colloids, which are large molecular weight solutions, and blood products. Crystalloids. So, conventionally, balanced crystalloids are fluids with electrolyte composition that approximates plasma, such as lactated ringers or ringers lactate, or a total calculated osmolality similar to that of plasma, such as normal saline of 0.9%. Thus, conventional crystalloids will distribute in normal proportions throughout the extracellular fluid space upon administration. In other words, expansion of the intravascular space will only increase by roughly 200 to 250 mL for every liter of isotonic crystalloid fluid administered. Hypertonic crystalloid solutions such as 3% normal saline have osmolality substantially higher than plasma, and the effect observed with these fluids is relatively larger volume expansion of the intravascular space. Crystalloids are generally advocated as initial resuscitation fluids in hypovolemic shock because of their availability, their low cost, and equivalent outcomes compared with colloids. However, take note of the side effects of crystalloids, which are primarily involving fluid overload and electrolyte disturbances of sodium, potassium, and chloride. Next would be colloids. Administration of exogenous colloids result in an increase in the intravascular colloid osmotic pressure. Now, these effects of colloids on intravascular volume are a consequence of their relatively large molecular size, limiting their passage across the capillary membrane in larger amounts. Alternatively stated, colloids can be thought of like sponges, drawing fluid into the intravascular space from the interstitial space. Next would be blood products. So, blood products are indicated in hypovolemic shock patients who have sustained blood losses from hemorrhage exceeding 1.5 liters. This, in fact, is the only setting in which freshly procured whole blood is administered. In virtually all other settings, blood products are given as individual components of whole blood units such as packed red blood cells, fresh frozen plasma, platelets, cryoprecipitate, and concentrated coagulation factors. This includes ongoing resuscitation of hemorrhagic shock, when packed red blood cells can be transfused to increase oxygen carrying capacity in concert with crystalloid solutions to increase the blood volume. Vasopressor therapy. Vasopressors is the term used to describe any pharmacologic agent that can induce arterial vasoconstriction through stimulation of the alpha 1 adrenergic receptors. While replenishment of intravascular volume is undoubtedly the cornerstone of hypovolemic shock, use of vasopressors may be warranted as a temporary measure in patients with profound hypotension or evidence of organ dysfunction in the early stages of shock. Successful treatment of hypovolemic shock is measured by the restoration of blood pressure to baseline values and reversal of associated organ dysfunction. And this is evidenced by restoration of normal urine output daily, warmth of the skin, general feeling of well being, and mental state. The likelihood of a successful fluid resuscitation will be directly related to how promptly the therapy was commenced. Now let's take a look at this algorithm. So we begin with assessment of the patient using the ABCDE approach and to assess whether the patient is hypovolemic requiring fluid resuscitation. Well, if fluid resuscitation is required, we will then move on to algorithm 2 which will be shown shortly. However, if fluid resuscitation is not required, assess the patient's likely fluid and electrolyte needs, gather history, do a thorough clinical examination, as well as clinical monitoring with the Muse charting, fluid balance charts, and weight. Do some lab-based assessments to identify the possible state of dehydration. Next, ask yourself if the patient can meet their fluid or electrolyte needs orally or do they need it intravenously. If they are able to, ensure nutrition and fluid needs are met and also look at the nutrition support in adults in the NICE clinical guideline. If the patient is unable to maintain their fluid needs orally, then you've got to ask yourself, does the patient have any complex fluid or electrolyte replacement or abnormal distribution issues? Look for existing deficits or excesses, any ongoing abnormal losses, abnormal distribution, and other complex issues. Now let's move on to the next algorithm. This is where we need to instate fluid resuscitation. So, initiate treatment by first identifying the cause of deficit and responding. Give a fluid bolus of 500 ml of crystalloids, which is 1 pint, over less than 15 minutes. Reassess the patient using the ABCDE approach and again decide if the patient still needs fluid resuscitation. Next, let's take a look at the third algorithm, which is routine maintenance. This can be started once the patient is fully resuscitated with fluids. Here, you will need to decide the maintenance of intravenous fluids for the patient by first understanding the normal daily fluid and electrolyte requirement. So, if the patient requires 25 to 30 ml per kilogram per day of water, for a patient who is about 50 kilograms, they would probably need 1.5 liters of normal saline a day. There should be also a requirement of 1 millimole per kilogram per day sodium and potassium, as well as think about the glucose needs. Reassess and monitor the patient regularly. You may then stop intravenous fluids when the patient no longer needs it. If the patient is unable to just sustain on intravenous fluid, you may then want to also begin nasogastric fluids or enteral feeding if needed. And finally, we have the fourth algorithm, which is replacement and redistribution. So, upon completion of fluid resuscitation, you want to ask yourself if the patient has any complex fluid or electrolyte replacement or abnormal distribution issues. In that situation, you may want to consider some replacement and redistribution therapies. So, existing fluid or electrolyte deficits or excesses, you want to look for dehydration, fluid overload, or hyper or hypokalemia. Estimate the deficits or excess and prescribe by adding or subtracting from the routine maintenance that's already available. Also, assess for any ongoing abnormal fluid or electrolyte losses, such as through vomiting and nasogastric tube loss, biliary drainage loss, diarrhea or excess of colostomy loss, melena, sweating, fever. These are all insensible losses. So, upon identifying the likely amount that has been lost over a day, you can then decide on prescribing by adding more on the routine maintenance. So, this is a comparison of different types of shocks. The second column here tells us about hypovolemic shock, and this is then followed by distributive, cardiogenic, and obstructive. If you notice, the difference between this shock can be seen from the aspect of the jugular venous pressure. So, if the jugular venous pressure is low or if it's a flat vein, you may want to consider hypovolemic due to the absolute low volume or distributive due to vasodilation. Again, the temperature of extremities also may differ. In septic shock or distributive shock due to peripheral vasodilation, you may actually appreciate warm peripheries. The left ventricular function on ultrasound is usually hyperdynamic in hypovolemia due to the compensation by the adrenergic response. And you want to also look for other findings which may help you support the diagnosis that you have made. For example, history of bleeding or dehydration, history of exposure to any infectious organisms, history of having any cardiac disease or cardiac symptoms on presentation, and history of any malignancies or venous thromboembolisms. Lastly, to summarize fluid resuscitation, there are a few questions you need to ask yourself before you confirm your resuscitative plans. Firstly, what fluid regimen are you using? Which type of fluid to give for the fluid regimen decided upon earlier? How much of fluid should be administered? How fast the fluid should be administered? And when should you stop the fluid? So we have come to the end of this lesson. Thank you for your time.